Good afternoon to everybody who's jumping on. We're just going to give it a little bit more time and we'll start right at that noon time. All right, as we hit this 12 o'clock time frame, we will go ahead and get started. Good afternoon. Welcome to the HFMA Colorado webinar series. We want to welcome you today and invite you to follow us on our social media pages for information about upcoming events and webinars. We do need to take a moment to recognize our annual business partners. Their support allows us to operate our chapter and bring our members quality education and resources. We hope that you'll take a look at them first when your organization needs services or support. A quick reminder that certification is now included in your membership. Study materials are online and all modules can be completed on demand at a time that's convenient to you. If you've thought about getting certified or looking to advance your career, contact the chapter today to get more information about getting certified. NASBA CPE credits will be available for this webinar. In order to be eligible for those, you must complete all 3 polling questions throughout the webinar. Today's webinar, Revenue Management Resilience, Putting Your Best People and Technology Forward, is being presented by one of our platinum sponsors, FinThrive. With that, it's my pleasure to introduce our speaker today, Jonathan Wiik. Jonathan has over 25 years of healthcare experience in acute care, health IT, and insurance settings. He started his career as a hospital transporter and served in clinical operations, patient access, billing, case management, and many other roles at large not-for-profit acute care hospitals. In his current role as Vice President of Health Insights at FinThrive, he is responsible for leading healthcare data insights and research. Mr. Wiik works closely with the market and hospitals on industry best practices for revenue management. He is the author of Healthcare Revolution, The Patient is the New Payer, and Revenue Evolution, Helping Providers Get Paid in an Era of Uncertainty, which was released in early 2020. He frequently speaks as a thought leader at state and national events. Jonathan is a past president of the Colorado HFMA chapter and previously served as a board member for the American College of Healthcare Executives and Colorado Association of Healthcare Executives. He holds a bachelor's degree in sports medicine and holds 2 master's degrees in healthcare and healthcare administration and business. Welcome, Jonathan.
Thank you. Thanks, Jessica. I'll share my screen here and get you guys going. Thank you for taking time out of your busy day to see me. I get to see most of you, I hope, next week at the HFMA Fall Summit. Hoping to catch you guys there and see what's going on and where we're at. I'm going to make sure I'm sharing the right screen here because it doesn't look like I am. Yeah, it should be. Is that showing the right way, Jessica? Can you see it?
It looks correct to me.
Okay, cool. Well, I'll go ahead and dive on in then. So this was a talk that Jeff Neeson from SCL Intermountain and I gave at HFMA Annual. And he couldn't make it this week or any week. So he had me go ahead and plunge forward, but I don't want to take credit for all of the content in here. Him and I tag team at that event and spoke to an audience of about 70 or 80 folks on the last day and was pretty well received. But I'll go through what we talked about and as always, reach out if you have questions. I'll have some time at the end. I want to talk about disruption a little bit. Your healthcare systems and hospitals are probably having a pretty bumpy year. If I had to guess, almost like flying an airplane through a bird strike. You're just trying to get altitude or get your margin a little bit better, and you keep getting hit by variants of Omicron, staffing shortages, the turning off of the faucet of the provider relief funds, and now you're having to kind of meet audit requirements and those types of things. And so as you're trying to get through this year, try to think about rethinking your revenue management strategy. Jeff and I were really emphatic about making sure that folks understood that you got to put your best foot forward. You can't recreate what I like to call the Franken cycle that you had before in your revenue cycle management. You have to rethink how you're going to manage that revenue given these challenges, given that you're not doing 3-year budgets anymore. And if you are, call me. But you're probably working month to month trying to figure out what is the latest crisis du jour, where's my cash, how are my payers behaving, those types of things. So we'll walk through all that stuff as we proceed forward. This, as revenue cycle leaders, you can see this gentleman, he's got questions like, am I going to get paid? Where are my claims getting stuck? Do I have enough staff at my registration and billing areas to make sure that we can continue operations, and just constantly struggling? He looks pretty stressed to me right now. And I remember during my days as chief revenue officer, had pretty stressful weeks for the most part as we were trying to figure out how to best staff to our organizational needs. Some trends in revenue management. I try to always have this slide like this where there's like 6 or 7 things that are going on that are kind of big takeaways. And the big one here really surrounds workforce. I think most of you are probably experiencing a staffing shortage. I just finished a labor report. I'm happy to send that to anybody on the call. Just go ahead and email me and I'll ship it on out. But it talks through where labor's at, what hospitals are doing to fix it, how long we think it's going to last, what are the impacts that it's having both organizationally on operations like staffing units and going on ED divert and those types of things. And then specifically what's happening within revenue management surrounding wait times in your customer call centers and billing, registration staffing, those types of things. So happy to share that report with you. It's about a 30-page slide deck, and also have an executive summary if you don't have time to go through that, but happy to share that. Automation obviously is a quick solution to some things. It certainly isn't the be-all, end-all, but a lot of revenue cycles are looking at ways to automate, not recreate the Franken cycle that they had before. I've talked about profitability. I'll have a slide here in a minute that talks about Kaufman Hall, but really having a pretty bumpy 2022. The Kaufman Hall index has not shown margin where we needed it. Payer mix is diluting. I have a slide on that as well. And then, health equity is something that we're being asked to look at. I've been looking at it, I would argue, for years, but it's finally became kind of at the forefront of an expectation. And then you have your patients. The consumerism and transparency wave has really turned into this frictionless experience wave, and everybody wants mobile. They want it to be easy to see you, get an appointment, pay their bills, see their results, and those types of things. And we haven't seen a lot of adoption in the EMR space. You're seeing a lot of business partners and providers out there trying to come up with a way to provide frictionless information to patients from the provider to where they're not having to pick up the phone and call. We're to our first poll question here. I think Jessica can tee that off to make sure that we get the answers from you. But I'm interested on what level of recovery you all are at your organizations. I won't tell you what nationally I'm seeing because I'm interested to see where Colorado's at. But take a few minutes and pick one of those. I broke it out by 5s. Are you back to normal and you're actually doing more than what you did back then? And this is overall across inpatient, outpatient, and ED. Are you about 5% below and you think you're going to get all the way there in the fourth quarter? Are you about 10% below, or do you think you don't know that you're going to come back? Where are you? We'll let a few more of you answer here. I didn't look to see how many people we had. We got about 20 or 30. We'll give it a few more seconds here to see what folks have, and it looks like based off of that, I'll go ahead and end it there. That most of you have said. I'll share this, I think, if it'll let me too. Most of you have said that, you're in that 90 to 94% range. We're stable, running a slight deficit. Some of you said you don't know. So that's interesting. You should find out if you're working at an organization, go buy your CFO or your VP revenue cycle, a cup of coffee and ask them, hey, how are we doing? what is going on at my organization. If you don't work at a healthcare organization, you're a business partner perhaps on this call, or you work in a different field, certainly, reach out to those colleagues in the market. There's not many of you that are in a surplus. I'm impressed by that. That's the first time it's 2 of you. I have not seen that much overall. Nationally, I've got a slide on it here in a minute. I think folks are running right around 95%. And by that, I mean about 5% of the industry in terms of ED and outpatient and inpatient volumes are below normal. Burnout has caused some of that. I think some hospitals have had to not run at capacity and maybe their ambulatory surgery or day surgery departments because of this workforce issue. Employee engagement has certainly dropped for the first time. You're seeing this disengaged number and this engaged number. Whenever these two lines are going together, that's a bad scene. That means you've got people that don't want to be there. And this is the first time I've seen it anyway in 20 years from a Gallup survey. I know you all are doing employee satisfaction surveys. You're probably doing staffing stabilization and those types of things. I've got a ton of stuff on that as well. If you're interested just in my travels around the country and speaking at conferences, I kind of hoard any deck I can find that I think is valuable, and have heard from many hospitals about some pretty innovative things that they're doing either monetarily or otherwise to retain staff and then recruitment, I think is a problem that we're just going to have for a little bit longer than anyone would like. Next week, too, at the Colorado HFMA Spring Summit, I'm chairing a panel of folks in the industry, and I think it'd be good to sit in on that and find out what they're doing. I had a prep call on that earlier this week, and was very interested to hear, how Children's and some of the other folks that are on that panel are doing to kind of counteract this stuff. Vail Health, and then I think one of our other sponsors was going to participate as a staffing. 1/3 of workers are done. I hate the word clerk. This isn't my language. This comes from Kaiser Family Foundation. I hate it when my team was called clerks. They're not clerks. But those schedustrars or people that manage a registration desk or in scheduling, 1/3 of them have said, I don't want to work in this anymore. This is what I signed up for. I can get paid the same wage down the street and not have to be here on a Saturday and not be yelled at by patients by how expensive or how long the waits are. And I'm sure you're seeing that on your front end as well. The other thing we're seeing is there really is been an open position crisis happening since the pandemic occurred. I'm a nerd. I follow the Bureau of Labor Statistics reports. I know you all do too. No, I'm teasing, but the JOLT survey comes out every month. It's the job opening and labor turnover survey, JOLT. The link's there at the bottom. Actually, very cool report to look at. And it tracks, like in that green line, the number of hires that hospitals have had. And this goes back to 2018. You'll notice, we had some disruption in 2020. That was when COVID happened. But we've seen this dramatic bifurcation. And I've actually got some updated information. I've ran this out through July. It's worse. It's surpassing almost the 2.3 million mark. So it's almost quadrupled in terms of the difference between the number of positions that are open and the number that we've hired. And that's tough, right? So you can't hire fast enough right now. And the openings just kind of be going, no matter how many fingers you're putting in the dike to try to plug that leak of people leaving your organization, it's getting worse, not better. It's impacting the operations as well. You're seeing changes in care model, maybe shutting down a wing or operating less hours of operation, maybe in an imaging department, your inpatient capacity I talked about, operating room, ambulatory clinics, diversions in the ED, having to keep patients longer because the discharge planners maybe are more of a scarce resource, and you're certainly not turning over beds as quickly as you like. That's also bled over to the revenue cycle. These are highlights from that labor report I was mentioning, and half of hospitals are reporting increased billing errors, a little less than half are reporting longer hold times, 44% are having cancellations, rescheduling, 26, about 1/3 are saying, hey, we'd love to comply with the Transparency and No Surprises Act. That's a nice to have. We're just trying to keep our doors open right now. And about 1 in 5 are talking about other operational deficiencies as they move forward. Premium labor has become an issue. Now, I've heard, and we had a panel at the last Colorado HFMA conference where we talked about what SCL and what Centura and I believe Denver Health was doing, and they all said that they had to use contract labor. They didn't have a choice, especially in nursing. But was resonating with me is that they said we can't continue to pay these rates, and so they've all kind of capped the rates. I'm seeing that nationally as well. This, probably is the worst that it's going to get, but 12% of that graph all the way over to the right, 12% of overall expenses now is premium labor. And that's a lot, gang. That's very, very high. Most hospitals that I'm talking to today are saying, hey, look, we got to pay premium labor, but we're not going to be held over the barrel anymore because of this supply demand issue. We're capping our out of network or our labor contract traveler rate at X by role. And if you're above that, staffing agency, tough, we can't do business with you because we just frankly can't sustain that. And then they're all trying to dial that down as staffing stabilizes, but it's pretty nasty. That labor report I mentioned talks about some of the longevity, and it's on the magnitude of years. We've all had short staffing issues in healthcare, gang, but this time it's for real, and it's going to be here a while. It's not going to get any better in the coming months, and I think 2023 is going to be a real bumpy year for healthcare based on some of the data I'm seeing, so I'm happy to share that with you when we have time. They are the challenge. Adjusted occupied bed per discharge staffing has gone up about $1,000 or $1,500 since before the pandemic. That's about a 27% increase. I don't think you're getting 27% more money from your payers or your patients, so that's why we're seeing negative margins. How long is this going to last? I think it's going to be, in the neighborhood of 2 to 3 years. I've talked to Fitch. This comes from Fitch, Moody's, and Standard & Poor's. Again, these are highlights from that labor report. They feel this is a fundamental macroeconomic shift. And executives are really put in a hard place right now. They're deciding whether or not they lay off folks because they're not getting the revenues from those volumes that I talked about versus, staying the course and keeping them there and losing money and margin and paying premium cost for contract and labor and travelers and folks and trying to see that. We're seeing that amplified in the specialty areas as well. All that aside, payers still are not playing nicely in the sandbox from what I'm hearing. That's the best I can put it. Pretty adversarial relationship. I'm not seeing a lot of collaboration in the payer market right now, and that's unfortunate. And I think, at FinThrive, we're really trying to beat the payer-provider collaboration drum. I've got some information on that as well. I think that has to happen for us to kind of get out of this mess. We've got to start figuring out how payers and providers can start having aligned incentives. And I think that path is a value-based care path, but fee-for-service and some of the immediate market pressures I've talked about has kind of stalled out some of those collaborative efforts. And a lot of hospitals just don't want to assume any more risk right now, and it's becoming very, very difficult. Leakage points that we're seeing, across the industry really surround denials, underpayments, payer policies, payer payment delays. Payers actually ended up in U.S. News. I've got that article if folks are interested in seeing it, where they're being called out saying you're just not paying claims on time anymore. You used to pay them, in 30 to 45 days. We're seeing unreasonable delays of 90 to 120 days, and you're paying the interest and you don't care for the out-of-timely penalties, and that's just not okay. So they have said, the payer community, hey, we're short-staffed too, and we don't have enough people to kind of process these claims. Well, I would buy that if most of claims payment and adjudication wasn't an automatic electronic process. So I think there's something that smells a little fishy there in my mind, and there's some idling. And if there's payers on the phone, I hope there are, please reach out. I love talking to payers. I used to work for one. I just think that we're in different universes right now. We need to kind of bring those back together and try to get folks talking to each other. This brings us to our second poll question. Where are you going to focus? Jessica will bring this one back up for us again. But where do you see, if you only could fix one thing? I know you're not going to be able to fix everything, but I made you kind of pick one here. If you've got to fix one thing in here, is it A, B, C, D, A, B, C, or D? And if it's, please don't a bunch of you answer other. That'll make it tough. But are you focusing on charge capture, clinical documentation, patient experience? Is the payer issue amplifying at your organization as well? I think that's important for us to understand as an industry where we're living. And I'm not surprised by these results. I'm seeing lots of folks say, almost 60% of you say that payer reimbursement is your number one priority right now. And a number two priority certainly is going to be your patients. So you've got to work on top line revenue as an organization. with your margins where they're at and your supply and labor costs where they're at, and kind of stating the obvious, but we've been talking about payer reimbursement, gang, for decades, right? What does that look like, and how is that going to get any better as we move forward throughout the next fiscal quarter and into next year? And what are some strategies? We'll talk through those here in a minute, but thanks for answering that. So I'm going to talk about Jeff's slides here. I'll do my best to kind of articulate what he was talking about, but we wanted to highlight what SCL has been doing in their revenue management and what they've done to kind of tackle this. Now, a lot of this was pre-COVID. I'll be fully transparent with you. It isn't, things that he's done magically through COVID, but Jeff had a really nice approach at Intermountain SCL in terms of doing an inventory of everything in the revenue cycle, both with what Epic can do and what his team can do and what his vendor management solutions look like, and just holistically looked at where can we improve? Let's put a list together and figure it out. And he said it wasn't easy. He had mentioned that, where are we going to start? Do we need to look at these KPIs? Do we need to look at engagement? And he kind of pulled from about 6 different sources. How are we performing in the market? How engaged is our teams? Do we need to manage people up or out? If people are leaving, why is that? They were doing exit interviews. I'm hearing in the market that you should be doing stay interviews as well. Meet with every single one of your staff and talk about what their plans are and how you can, what would make you stay here? Because they're leaving, gang. About 30% of your workforce is leaving in the next 2 years. I'll say that again, 30%, 1 in 3 of your workers is leaving in the next 3 years. And that's not me, that's the market saying that. So you should be talking to your teams about keeping them there, because if you don't have people, you can't do the work, no matter how much automation or technology you have. Something to think about. Re-benchmarking some salary data and budget data. Jeff had mentioned when we were at HFMA Annual, they were very happy and pleased that they did a lot of this stuff because it helped insulate them from some of the things that happened during COVID. This was their plan in kind of 4 stacks. They let data tell their story. I like what Jeff says, ask what's stupid. If you know Jeff Neeson, you could hear him saying those words. The data will tell you what's broken or where you're not meeting benchmarks. They put a list together. It may be a really long list, but that's fine. How do you eat a 500-pound element? You eat it one elephant. You eat it one bite at a time. And prioritize those things. Which things are going to get us the highest yield and drive cash and get us to our operational goals the quickest? And finally, draft that plan and execute on it. I loved what he said. Nobody plans to fail. We just fail to plan. He said it felt like this. He had this big rock on his back, this giant list of stuff that was just broken, and these steps of where you have to hop from milestone to milestone when they first started. So they had to continually execute on their plan. They provided their direct and indirect report feedbacks. He got that back from his team. Explained the why. Why are we not hiring folks right now? Why are we in a freeze? Why can't we buy that piece of software? How come Epic can't do that? Was very transparent and excited and enthusiastic about the things that were there. And he was being a good steward about the plan to understand, hey, this is where we're heading. This is what we're doing, and this is where we're at. And Jeff said he's more than happy to share those plans with you and get him, and feel free to bug him and tell him I sent you. He'll love that. And then maximize those relationships. Nothing happens in revenue cycle without IT. You've got to have folks. I'm seeing revenue cycles in the industry actually have dedicated IT FTEs that are like their staff person these days. They don't work for IT, they work for revenue management, and they are liaisons over to the IT department, so they have the access to move those tables. They're Epic engineers, those types of things are Cerner engineers, and they pulled together as one team to kind of execute that. I saw a question in the chat. I'll go ahead and answer it about stay interviews. I'll find some stuff on that, on how often they should be performed. I managed almost 300 people in my revenue cycle. I think I had 5 direct reports when I left at the director level, and senior manager level. And I told them, hey, make sure you're having one-on-ones weekly with your teams if you can, at the very least once a month. And I met with them once a week. And those one-on-ones are important, but these aren't one-on-ones, gang. What these are different. These are, hey, how's it going? How's your family? How's work going here? Are you happy? Are you not happy? What's driving you nuts? What can I do to make sure that you're Everything's out of your way. I want to make sure that you're happy to work here and don't want to leave. And you're going to hear, well, I want a raise. I want more flexible hours. I want to work from home. Guess what, gang? That's the market, and you got to figure out how to make those things. We've been underpaying registrars and schedustrars and folks in revenue cycle for years because it was valued as defined as a cost center, not a revenue center. You have to invest in those things. Do a market survey, find out where their average hourly rates are, look at career ladders, get it figured out, but you're going to have to invest in your staff if you don't want to lose them, because it's going to happen. And those turnover rates are going to be in the high teens to low 20s. So if I was running a revenue cycle today, what I would communicate probably to my direct reports and kind of cascade down is that, you should be performing stay interviews with all of your associates or colleagues, probably weekly if you can tolerate it, if not, if the very least monthly. I think if you wait a quarter, you're going to lose some folks out there. So monthly would be my recommendation at a minimum. If you can do bi-monthly, that'd be even cooler. And maybe little huddles in the morning or something too. I don't know, but you gotta figure it out. A lot of monitoring and reporting Jeff had here, using the reporting tools to gather data, really informing that and really making data-driven decisions. They worked on the plan in September, and then they eventually get to the point where you're doing a one-year plan, but they kept working, and it wasn't like this insurmountable list, but it was definitely 3 to 4 years worth of work, and they didn't want people like my teenager. Oh my God, I'm so behind on my homework, I can't do it. It's like, look, just do it a little bit at a time. Get one class done at a time, just like Jeff did. They did one area at a time. They focused on cash goals first, and then maybe they focused on claims goals, and did those things. But you must put things into a plan. I used to tell people, if you don't put it on the burner, it's not even on the stove. It's not even on the back burner of the stove. So get everything written down, get a plan, put it on the list, and start prioritizing that list, and then understand. And that'll also help you kind of substantiate the amount of resources you need. And then also, not to be a fear monger, but say, hey, if we lose 5, 10, 15, 20, 35% of our staff, these 6, 12, 18 things aren't going to happen. We're not going to get it done. And the monetization or the risks to us is that. One of my mantras when I was working in the hospital was, my job is not to judge, but to provide information. And I want to make sure you're informed that based off our staffing levels and with the projects and the things and the goals we have, I need X to deliver Y. And if I don't have X, then Y is going to change. And it's very important. You should have those conversations at your fingertips. SCL kicked butt. These are really, really good numbers. National average right now for AR days is around 43. They got them down to 42. This is pre-COVID, gang. So I'm sure they're running in the high 30s now. Ambulatory was 34. Very, very good. They got discharge not final DNFB down to 2.6 days from 7. Awesome there. AR over 90, 22 and a half. A little high there, but it must have been really bad before. Avoidable write-offs. That's Jeff's really proud of that. I don't see a 0.5%, gang, in the market that much. Industry average is anywhere between 1% and 4% these days. They're knocking it out of the park. I don't know if you know either. HFMA gives out MAP awards, and SCL for like the third time in a row won a MAP award for revenue management. Troy Spring was very, very happy at Annual about that. And part of that was definitely probably related to their performance with denials. So if you want to fix denials, I would give Jeff and Troy a call over there at SCL, because they've got a good program, and I have not seen a 0.5% performance at an organization consistently like that. Cash was down to half a day from 1.5, and they reduced all that, and they also reduced their budget. So it's just phenomenal work. He's very, very proud of what they did. FinThrive partnered absolutely with SCL at that. This is a case study we put together with them. We've been partners with that organization for about 16 years, and have delivered $86 million to them, about $6 million a year across various areas of revenue management, primarily in the insurance discovery, Medicare beneficiary bad debt, and other areas. And we have outlines, and I have this case study if you'd like to hear it, but always want to drive revenue and demonstrate your value. My advice to you on the phone is you absolutely should hold your business partners accountable. Call them, what have you done for me lately? I want to see a report like this. I want to see what we're doing. I want to know what my spend is against what my yield is from you. And if they can't do that, then you might want to consider replacing them with someone else. So what does good look like? I kind of finished the talk at Annual with this, and I always like instrumentation and dashboards. I'm a nerd. I like to look at what a hospital can and can't do. And I always want to see like what is national doing, what's regional, what's state, and where are you? Are you at or above? Are things better, worse, or same for your organization? So I like dashboards, and pilots have to know, what's your altimeter, what's your airspeed, how much fuel you got, how are things going, are we on time, those types of things. So what does good revenue excellence look like? Well, we've seen Vendor Fest. I mentioned Frankencycles before, where there's been lots of point solution partners out there kind of saying, hey, do you want this? Do you want that? Do you want to buy a watch? And my revenue management system had 26 different vendors in it, and it was a headache. 26 invoices, 26 different connections to IT, 26 different conversations I was having. So I was talking to probably 2 or 3 different business partners a month, and was really trying to get that consolidated down to 10 before I had left. But this Vendor Fest or Frankencycle that you're seeing has just tremendously grown, and it hasn't delivered. You've seen about 2/3 of hospitals using 2 or more vendors. Actually, the more vendors you have in your revenue cycle footprint, the more issues you have. That's a study that's out there. I'm happy to share it with you. And you also have kind of all these umbilical cords that are out there and more file specs. So as we're talking about that, that brings up our third poll question, and Jessica will bring that up for us. But where do you see opportunity in consolidating RCM vendors? Given that you may or may not have a Frankencycle, is it all of these? I have a feeling a lot of you are going to answer that. Are you going to focus on the front, middle, or back? Is that more of a priority to you? Do you have duplicity? I will tell you, I see most of the duplicity in the front. I see oftentimes when I'm on site at an organization, I'll find 3 or 4 different eligibility vendors. I'll find 2 or 3 different estimate folks. I'll find 2 or 3 different charity models, and those types of things. On the back end, it's pretty tight. I think you've got usually 1 or 2 or 3 folks kind of handling different areas, usually separated out by payer or types of things. I'll go ahead and share this now. You guys are getting very, very disciplined in the polls. I appreciate that because it helps move along. But I'll share these results. You guys mostly said all of the above, about 44%. So you're kind of focusing on all 3, and I'm pleased to see that. I'm pleased to see that a lot of you are thinking about that, and you're also trying to look at all the areas. Middle, there's not a lot of duplicity there. You probably have 1 or 2 folks doing charge capture, or CDI, those types of things. But a lot of opportunity, I think, in all of these, and really important as you move forward and doing it. But thanks for answering that. I'm gonna keep cooking here. Let's get rid of that and boogie on. This is what the market's doing. This is a survey that I like. They surveyed 205 CFOs and VPs of revenue cycle. Kind of an even spread here, but they said, hey, what are you doing to navigate staffing in revenue cycle right now, given this shortage that we've talked about, the profitability? And 1 in 3, that upper right corner, that bright green, said that they're looking for a strategic partner like FinThrive or others that are out there to help them go from A to B in a holistic way. They've adopted technology or software. They've looked at, okay, we can't do this within Epic or Cerner. We've got to have a third-party best-in-breed solution of some sort to optimize, because we're leaving cash on the table, be that in contract management, insurance discovery, estimation on the front, whatever those types of things are. But we have to automate these things to where our teams are empowered on the front end to have the right information at the right time with the right patient to do that. That consolidation thing we talked about, redundant systems, 1 in 4 of you all are looking at, hey, vendor A and vendor B are doing the same thing. We really need to get those down to 1. Let's send a term notice out to the other one, or have them do a bake-off as they move forward. And then attracting and retaining talent, that's kind of a duh, but working on their stay strategies and their staff stabilization. And as I mentioned, I could share this report and the staffing one with you about some of the strategies that are out there. Keeping your revenue management on track with staffing challenges, really, I had 3 stacks here. You've got to automate, not recreate. I like to say that. Don't recreate the Frankencycle that you had before. You had an opportunity. COVID shined a light on your organization. You probably had work from home where you may or may not have had it before. And you've moved into an organization to where you're maybe trying to rebuild what you once had. Don't just cookie cutter what you had before. Jeff and I were very emphatic and annual about, you have an opportunity, like his plan said, to look at what you have, take an inventory, prioritize that, and execute against it, and really, really look at what can you automate. RPA, I've got a deck on that too. I know it was one of those things that used to make the hair on the back of your neck stand up. You've been in revenue cycle. I was there with you. It absolutely is technology today that allows many, many, many things to be automated to where your teams aren't having to pick up the phone and call a payer or jump out into Navinet or the claim clearinghouse and resubmit things. A lot of that stuff can be automated overnight. They don't get sick. They don't complain. They don't smoke. They don't drink. It just works. A bot works 24/7 on that stuff, and it's important to look at it. And they average anywhere between 20 to 30% savings. Again, this isn't replacing staff, but it's if you're in a deficit, don't just try to rehire back to your run rate. Look at how you can do business differently and automate as you move forward. Knowledge management is something that's very closely related to stay interviews, the second stack I'm talking about there in that lime green. Make sure that you are educating your staff and using, third-party education or having them attend conferences like HFMA. I'm the past president. Get them there. I know it's tough. We got provider packs and things, but have your folks be in the know what's going on. Nothing has an employee leave sooner than being uninformed and being sad and not knowing all the answers. Now, you're not going to be able to tell them all the answers, but the more educated, the more empowered, and the more engaged your team is. What is the latest that's going on with Medicare Advantage? What's going on with Medicaid? There's this new rule in Colorado that says if you don't get an estimate, it's free. What does that mean? What patients are asking me about it. The No Surprises Act is out there. What does that mean? I can go to the ED and get everything for free now? I mean, there's lots of stuff out there that's changed. It's a constant market of change. Very, very important to continually educate your teams on what's going on. If you don't have dedicated time to educate your teams, you better get it. And I would recommend at least spending a day out of a quarter. That's a lot, I know, with your entire team, and you might have to spread it out on what's going on in the market and what types of things they need to think out, and there'll be some specifics in your organization as well. And then we talked about consolidation as well. If you're spending money in 25 different places or 26 like I was, you can get that down to 10. Even if you can get it to 15, you're saving on 5 invoices, right? And the market's ripe for that now. There's a lot of partners out there that are saying, look, you got to look at end to end. You got to figure it out, and you can, and I encourage you to do so. I wanted to put 10 tips in here for retaining talent. Oop, I think I saw a question come through too. Let me go look at that real quick and see. Will you be sending the slides? Absolutely, Jackie, we'll be sending the slides out. I think Jessica already put them in the chat too, if I saw there was a link there, but I'll send them back out if not. But recognize retention starts with recruiting, and that's kind of a dub, but are you hiring the right folks? Really look closely at that. I know you're like, oh, I've heard this before. You heard it, but I always used to say saying and doing are two different things. What is your recruitment strategy? What's your relationship with HR? What open positions do you have? Are the resumes like on Pluto and you're on Earth? Who are they calling? How are things coming in? Where are things posted? What incentives are you putting in place? Are these people staying when they're there? You need to look at all of that kind of holistically in those metrics to understand where you're at. I'm not sure why. There we go. Identify candidates who will stay. So when you're hiring, you're like, hey, we've got folks that have came and went. I don't want to train you up. Think about having retention bonuses or interviewing for, look, we need people that want to stay here and grow, show them the career path, try to get them on the track and on the rails for the time that they're there. Identify the outlook and the vision of your organization. Provide ongoing education. I covered that. Remote work, love it or hate it, you got to do it these days. I've been told that the job market's actually more competitive now for revenue cycle because it's a national pool. And you would think that would make it easier, where in fact folks are interviewing all across the country and they're being picky with you. It's not about you finding somebody. It's like, maybe I won't interview second time with you because I like this place out in Texas. They've got better hours or better wages, those types of things. So think about that and how competitive you are. I talked about competition with compensation. Deliver. You can't give lip service. You got to be honest, truthful, and transparent. You saw that in Jeff's slides as well. Was enthusiastic. Tell them the why. This is why we're doing things. You should be, any conversation you're having with your teams and your leadership should be as if every single staff member's in the room. And I know that's tough to do, but you got to do it. Trust me and thank me later about that, but you got to have a very transparent and wide open, engaged workforce. Engage them however you can. I've seen gamification here. I've seen monetary things. I've seen FTO. I've seen all kinds of different things, job shares, shifts, team builds, but make sure that they're there. Tell them the difference, to celebrate your successes. Hey, gang, last month we hit our cash goal. Have lots of dashboards. Hey, our denials went down by 0.5%. And these aren't just pizza parties. Hey, Jonathan, turned over 12 more claims than everybody else last month. Let's all give them a hand. Do those types of things. They matter. We all have worked for a long time in our careers, probably. We all love getting attaboys or attagirls, and you can't give enough of those. So that's the best way to engage. And I don't think it has to be monetary. I mean, go talk to the coffee lady at your hospital and get 10 cards and hand them out tomorrow. You'd be amazed how much longer your staff will stay. But get them there, get them engaged, make sure that you care about them, ask what's going on in their life. We talked about data. Jeff had that in there. My mantra is, in God we trust, all others bring data. You gotta have that. So make sure you're making data-driven decisions. It's tough right now. There's a lot going on. Make sure you're looking at where you have opportunity and why, and make sure you've got data to back it. And then be prepared for it. What would your department look like if you lost a third of your staff? What types of things could you not do? What would your AR days maybe look like? What would your denials look like? What would your point of service collections, your cost to collect? Those types of things, your registration areas, your call centers, what would that look like? I think it's good to kind of look at that and then maybe evaluate, well, do we need to have an outsourcing option for when we hit those troughs or not? Or do we need to, think about hours of operation and flex plans as we go up and down? Believe it or not, the CDC, I usually don't like to quote them. They've got really cool strategies and things out there for surge planning. And it's primarily clinical, I'll be honest with you. But you should do revenue management surge planning too. But just flip it. Like, what if a lot of people left all of a sudden? What would that look like in my organization? How would I still submit claims? And what would that do? And where are critical levels? And where am I at? Could I shift folks? Do I need to cross-train? That type of thing. But it's going to happen, gang, and you might as well start planning for it now. Skill-based hiring is something that's very important as well. And I think, I used to say I don't hire necessarily for skills. I hire for talent. That's changing. I think you need to look at, what are the things that need to get done, not the role that you're trying to hire, and really look closely at that. Take a job inventory, try to figure out what are the things that critically have to get done, like Jeff did in that list he talked about. And then do I have the right people in the right seats on the right buses, and move it around and make sure that things are in the right place. And look beyond those educational requirements. You might have, you have to have a bachelor's degree. Do you really need a bachelor's degree for that job? And think about that critically. Do you really need one today? And look through and do an inventory of those job descriptions to make sure. Unconscious bias too, and I don't think this happens out in Colorado as much as maybe other states, but make sure that you're being the DEI champions in your organization and hiring from whatever creed that's out there, because trust me, you need them. And it's very important to look at that and look at the composition and make sure that you're reaching out to those minority and ethnic groups in your recruitment efforts as well. And oftentimes you don't even know, but that's that relationship with HR I was talking about. Make sure that where things are posted and how it's being done are accessible by all the people that could possibly do that role. And that sounds silly, but you'd be amazed by turning over those rocks, the types of things you could find. And then internal moves to respond faster. Where can you shift folks around? I talked about that as well. This comes from a McKinsey study that's very, very good, by the way. It's down there in the footer. You can go check it out. This is what good looks like. These are the Q2 benchmarks, or Q1 benchmarks as of 2022. I'm a big HBI guy. I'm happy to send you some more things from them. We don't get any money from them, but I really love Health Business Insights. They're owned by a company called Clarivate now. But these numbers come from there. I've got them at a regional level too, if you'd like to see, how Colorado's doing with these. But you got to track these. I call these the Big 10. If you have a dashboard, make sure these are all on there. If they're not, I'm certainly can help you try to figure out where they're at. As I mentioned, AR days are running 44. If you recall from Jeff, he was running sub 40. Right now, he's running 0.5% off of 1.3% for denials. I didn't see his cost to collect number. Bad debt and charity are there. Point of service collections is an interesting one. That one used to run in the 2 to 3% range, and I think you're probably seeing at your hospitals that it's not about collecting money at the front desk anymore. It really is surrounding navigation and payment plans and financing and charity care coupling. But it's absolutely imperative, let me be clear, to run estimates on every single one of your patients, everyone, not just the ones that are scheduled. I was at a conference last week where I heard Banner speak, and Banner Healthcare, one of our clients as well, says they run them on everybody. And I can send you guys that deck if you want. So every ED patient, every inpatient, every surgery, they know that some of them are going to be wrong. They know that some of them have high variability, but they start the process. And I'll say that again. They start the process with the patient. Healthcare is expensive. They at least start somewhere. It's a buoy in the ocean. Very, very important to look at that. And it's not necessarily an output of point service collections. Banner doesn't even track that metric holistically. They track things like estimates performed, percent of obligation collected, so that they can actually make sure that they're actually estimating things and then tracking what they got against those. That's a more fair metric if you think about it. AR days over 90, clean claims rate, you guys know those. And then finally, days cash on hand. And days cash on hand is a wonky one. That's a Becker's number. I hope most of you have the high hundreds of cash on hand. I've seen some hospitals in the South and in other more impoverished areas only have 20 or 30 days. I've seen even single digits. In my mind, if you've got single digits cash on hand, that's an accounting issue because payroll and other expenses may come up, and with this turnover and stuff, that'll be pretty difficult. Here's that checklist. I always have a checklist with my talks. This is a great one to print off and kind of walk around. As I've said with every one of my talks that you've seen, do not check the green box unless you really feel that's hardwired in your organization. I've talked about eligibility. You can run it all day long, but yet you still have $3 million, $4 million, $10 million in denials at the end of the year. Why is that? Where's the disconnect? You ran the transaction. Did you look at it? Did you let it go by? Did something change? That needs to be hardwired. And I've talked to so many hospitals like, oh yeah, we do great. We've got an RTE, an Epic, and we have a work queue, and it's awesome. We have people working them, and isn't this awesome? And I'll go pull it out, and I'll be like, you have $3 million in denials. What happened? And they're all eligibility, and they're all on the front end. Something disconnected. You didn't have a lean process to where the and-on, it's called, where you stopped the line and switched it to self-pay or flipped it. Something changed. You've got to have that process hardwired. Sometimes that involves having insurance discovery or rerunning an eligibility check or having a feedback loop to what they were eligible for really changed. Why am I being so emphatic about that? Transparency and No Surprises Act. You're going to get nailed for it if you don't start figuring out how your eligibility runs and you aren't running proper benefits. If you're off by more than $400, for example, on an estimate, you're going to start seeing some very interesting things happen from a penalty standpoint. My point that I kind of ended with the talk, I think, with Jeff was, where is your data coming from a provider and payer standpoint? Are you optimizing all those data bubbles? And are you executing, to use Jeff's word, in contract management, advanced workflows, denial prevention, not denial management, and your reporting? Can you check those circles on the right and know that you're doing them well? Really is not to recreate what you had before. It's to automate what you had before. Don't create another Frankenstein cycle. Look at the analytics, like Jeff said, with the data. Look at where you can automate things through your own workflows or technology. And then, like I said, it's ripe for it right now. I think it's very, very easy to look at getting all of those use cases that I talked about there. Here are 4 more. Adjustment types on types of bill, Medicare, Medicaid eligibility, large late charges. All of these are case studies that I can share with you. You can see the use cases in the boxes in each one too. These are all things that a robot can do today. And they can figure it out and they can load it and it can absolutely automate stuff to where your teams are only working on the really, really, really hard ones. Did I say really? The really, really hard ones, to where the easy ones where they just have to, for instance, suspend a claim that needs medical records. That's going to happen. Stop the claim, add the records, then send it. Or run a script in the middle of the night that does that automatically for you. But just don't ship it over and hope that they're going to forget this time. Here's a newsflash. The payer's not going to forget. They're going to send it right back and say, I'm not paying you anything until you send me the chart. So that's just one example of one where it's just a no-brainer. Like, have that set up, have all the links set there to where the discharge summary, the S&P, whatever, drops onto the claim and goes, writes the letter, faxes it or emails it, however it works through the portal. Very, very, very interesting and simple workflow. Rethinking revenue management in the healthcare ecosystem is something I want you to think about. If you remember when we started, I talked about how disrupted the system is. There's lots of bird strikes. You want to have less of those, less vendors. IT is very, very busy. with cybersecurity and with the Epics expansions and all the other needs from the hospital. Revenue cycles often bastardized down to like at the bottom of the list. Very important to bring them up and have that stuff going to get these synergies and ROIs as you move forward. I'll finish with the slide and then open it for questions. But Franz here, Franz van Houten from Philips, has said, if we're to ensure that healthcare remains affordable and widely available, we have to radically rethink how we provide management in collaboration with key system partners and apply that technology. I love this quote. Now, Philips isn't in revenue management. He's not a finance guy. If you don't know who Philips is, they do a lot of kind of Internet of Things in a hospital, a lot of pumps, a lot of diagnostic equipment, those types of things. But this applies to us too, gang. And I love this. And I want you to radically rethink about where you're at today, where you want to be, do that plan like Jeff talked about, and execute on it, and then reach out to me if you need any help with it, because I'm happy to help. I think that's it, Jessica. I'm going to open it up for questions. I'll go out to the chat, see if I see another one. It's yours, so that's great. It looks like, Teresa, you'd like to see the regional data for Colorado, so go ahead and email me, and I'm happy to send that out. My information, I think, is on the last slide here, so I'll put it up so you guys have it. Yeah, there it is. 2 I's and a K, too, so watch out as you spell, but you can take a picture of it or screenshot it there. But yeah, happy to answer any questions that folks have if they want to raise their hand or get some stuff done. But please let me know if you have anything I can answer. And thank you, Jessica.
Thank you so much, Jonathan. We really appreciate your time. I'm not seeing anything else really. Oh, I do have a raised hand. 1 second. It looks like I will unmute here. All right. I have given you permission to ask your question, I believe, Althea. You might have to accept the unmute.
Can you all hear me okay?
We can. How you doing?
Awesome. Great. Thank you so much, Jonathan. That was great information.
Cool.
Thank you all for hosting this. I just wanted to ask, have you seen organizations that centralized their insurance and scheduling services revert back to facility specific insurance verifiers? Because I do know that that was a trend at one time, but the training and the staffing and the job force that you were talking about, I know has impacted that.
Yeah, I think it's a mixed bag to answer you, Althea. I think it depends on like super huge mega systems. Absolutely. I think you're seeing, a commercial team with specialists, they call them, like in United, Aetna, Humana, Blue Cross Blue Shield, because those knuckleheads have rules that change all the time and you can't possibly teach, the 100 folks everything. Those teams are a jack of all, they can't be a jack of all trades, but they've got some level of specialization there. I don't see it prevalently, frankly, because you'd love to do it, but you can't. So you kind of have to have everybody an inch deep and a mile wide because there's just not enough of them right now, and you're maybe in a deficit of 20 or 30%. So you kind of have to teach everybody a little bit of everything. I think you're exactly right. Centralizing kind of created some challenges with that because everybody's kind of at the same level of education. But when someone leaves, that creates that gap too. So it's tough. There's a lot of knowledge source information out there. We've got some too as well on payer types of things. I think that education point I made to where you can kind of plug things away about those insurance rules. Denials is a good metric from that too, or underpayments. If you're seeing a behavior from a payer that's causing folks, maybe do some dedicated education there. But I haven't seen folks reschedule holistically their teams yet, unless they're like mega huge, like a Mayo Clinic or an Athena or Advocate or Northwestern, things like that.
Okay, good to know. Thank you so much.
You bet.
All right. With that, I don't see any other questions or any other hands. So I think we can let everybody have, 7 minutes back in their day today. Just want to thank Jonathan, first and foremost, for sharing your expertise with us. We really appreciate that. The presentation is in the chat box. If anybody would like to download it prior to jumping off, that is available there. For your NASBA certificates, if you guys could just give us maybe a week and a half or so to get attendance verified and everything like that, and then we'll send those out. Let's see. Also, like Jonathan said at the beginning, we have our fall summit coming up next week. If you haven't registered yet, there is still a little time. We'd love to have you join us. Reach out if we do have some provider coupons and some scholarship opportunities if you're interested in coming and need some assistance with the registration fee. The recording will be available. Jessica, it looks like you asked that question. We'll have that out shortly. And I will send an email out to everyone with the link to that and all of that information. So I think that concludes everything for today. Thank you all so much for sharing your lunch hour with us and have a wonderful day.
Thanks, everyone. Talk to you later.